Hello, my name is Michael Perch. I'm the Program Director at Retransplantation University Hospital, Copenhagen, Denmark, and Associate Professor of Clinical Medicine at the University of Copenhagen. In any solid organ transplant, there is the possibility of acquiring chronic rejection. And in lung transplantation, this is defined as chronic allograft dysfunction, or CLAD, C-L-A-D, which is an umbrella term for the clinical manifestations of pathological processes leading to a persistent deterioration of lung function. Previously, there was only one phenotype, which was named BOS, but this has now been subdivided into the obstructive phenotype BOS and a new restrictive allograft phenotype called RAS. BOS and RAS are not static. You can develop BOS and then it can develop into RAS or the other way around, or you can also have a mixed phenotype. The most common phenotype is BOS. In an ISHLT registry study, there was a cumulative incidence of BOS of 9% after 1 year. After 5 years, 51%. In a cumulative endpoint combining BOS-free survival and death, the median BOS-free survival was 3.5 years. Well, BOS can occur quite early after lung transplantation, within the first 2 years, and can show itself in many ways. It can be rapidly progressive, or it can be more slowly developing decline in lung function, which eventually will affect the patient quality of life and the ability to perform daily activities. Some of the common symptoms of BOS is shortness of breath, decreased activity and tolerance or endurance, fatigue, dry cough, and sometimes there can be increased mucus production. BOS is also the primary cause of death in lung transplant recipients, and also the primary cause of allograft loss after 2 years. A recent German study looked at the disease burden associated with BOS, and the study showed that the patients with CLAD lost 1.3 life years and lived for 0.8 years with their disability. There's also an increased economic burden. The more severe the grade, the higher the cost. And this cost is mainly due to inpatient hospitalization. The pathophysiology has multiple pathways, and many risk factors have been associated with the development of BOS. Some of them can be infectious, some can relate to insufficient immunosuppression. These factors all in some way relate to recurrent injuries of the lung allograft, which results in excessive scarring and an aberrant healing process. There can be endogenous or exogenous risk factors which lead to primary damage of the airway epithelium, which leads to injury through innate adaptive immune responses, leading to fibroblast proliferation and deposition of extracellular matrix, leading to obliteration of the bronchiole, meaning that the air cannot move back or forth in that part of the lung, eventually leading to a reduction in lung function. the risk of insufficient immunosuppression leading to, for example, acute cellular rejection or antibody-mediated rejection, or lymphocytic bronchiolitis are all risk factors for developing BOS at a later stage. Also, infectious diseases, especially respiratory viral infections, but also colonization with, for example, Pseudomonas aeruginosa or Aspergillus fumigatus, or CMV can lead to injuries in the lung, which can later on develop into BOS. Endogenous, like injuries caused by GERD, diffuse alveolar damage, primary graft dysfunction early in the post-transplant process, exposure of self-antigen like collagen type 5, or acute cellular rejection, or lymphocytic bronchiolitis, or antibody-mediated rejection, AMR. It's important to, if at all possible, prevent tissue damage, which can lead to these immunologic responses leading to BOS, and also modify the aberrant repair. First of all, we want to reduce the risk factors if at all possible, ameliorate toxic effects like air pollution, smoking, reduce the risk of viral infections if possible, and prevent triggering events, and dampen innate and adaptive immune and autoimmune responses, thereby minimizing primary damage to airway epithelium and prevent the immune-mediated damage leading to BOS.
Hello, I'm Howard Huang. I'm an associate professor of clinical medicine at Houston Methodist Hospital and Weill Cornell Medical College. And I'm currently the medical director of lung transplantation at Houston Methodist Hospital. Typically, lung function monitoring begins shortly after the patient's recovered from the initial surgery and is able to participate in spirometry maneuvers. Many of these tests are initially done in the office, but as the patient becomes healthier and is coming in less frequently for office visits, many centers have implemented home spirometry monitoring as a way to continue to gather data. It takes time to establish a baseline after transplant, and we typically tell patients it takes about 6 to 12 months for that to occur, depending on how the surgery goes and if there are any major complications, and how they recover from it. And but once that baseline is established, then future spirometry measurements are compared against that baseline. So what we consider a baseline is the average of the two best FEV1 readings that are taken at least 3 weeks apart. And again, it takes several months at the very least to establish that baseline, and some patients take much longer to reach their peak. So when should we consider additional investigation? It's typically if there is a deviation from that baseline or greater than or equal to 10% drop in their FEV1 compared to their historic best. And that should trigger additional investigation for reversible causes of lung function loss or the possibility of CLAD that's developing. Spirometry remains the best tool we have to continue to gather that data. And it's important also to remind patients that as time goes on, the risk for developing CLAD increases. Therefore, the importance of continued monitoring as time goes on that remains. This is an important point because in order to establish a diagnosis of CLAD, we must exclude other reasons for loss of lung function or reduction in FEV1. So there are several reasons this can occur. And first of all, it's important to recognize that gradual loss in lung function is a normal process of aging. And so there may be gradual loss of lung function in the absence of any acute or chronic rejection of the lung allograft. In patients with single lungs, sometimes loss in lung function is related to disease progression in the non-transplanted lung instead of dysfunction in the transplanted allograft. There may be surgical reasons if the patient has had additional procedure, mechanical reasons associated with loss in FEV1, such as airway obstruction or stenosis that can occur after transplant as a complication of ischemia in the airways, and also patients who gain a significant amount of weight will see a change in their lung function. We're always considering if there's been a development of a new infection, or in patients who have been colonized with a certain organism, such as mycobacteria or fungus. Is there an exacerbation of an existing infection? In patients with single lung transplants, that there may be more prone to these infectious types of exacerbations because of the reservoirs of infections that dwell in the non-transplanted lung. Other factors, immunologic factors, include acute rejection, which is more likely to happen within the first 6 months after transplant, and antibody-mediated rejection, which can happen early after transplant or late after transplant. Other things to consider are compliance or adherence to immunosuppression. Finally, other things such as drug toxicity, development of malignancy, thromboembolic disease. Those are all things to consider. Biopsies and bronchoalveolar lavage are considered adjuncts, tools to further delineate the cause of lung allograft dysfunction. It's useful for identifying infection and perhaps less sensitive for identifying causes of rejection, such as AMR or acute cellular rejection. The utility of biopsies, transbronchial biopsies, for establishing BOS is quite limited due to the heterogeneous nature of the process and the random sampling process that occurs with transbronchial biopsies. And but it's important to consider bronchoscopy with biopsies and BAL to exclude other reasons for allograft dysfunction, such as infection. The BAL cytology and also cell counts may give you a hint of what's going on. So typically, if there's a high degree of neutrophilia, you would consider, is there an acute infection? But and a chronic BAL neutrophilia is also a feature and maybe a treatable feature associated with acute lung allograft dysfunction that is associated with a reversible cause. BAL and neutrophilia has been associated with CLAD. Other things such as seeing eosinophils in the BAL cell count and differential may give you increased lymphocyte counts, and the BAL may give you more information about whether this is CLAD versus other acute processes. Pulmonary function tests are still the best tool we have to assess for CLAD. In order to establish that diagnosis, that's actually part of the definition. The CT also gives you additional information in terms of phenotyping. CT has its limitations in terms of how often you can expose patients to ionizing radiation, and also the overall sensitivity for detecting CLAD when you evaluate these modalities, the spirometry and lung function testing is still the most sensitive tool that we have, although other tools are being assessed or are being introduced for this purpose, including oscillometry. BOS, again, is the most common phenotype. This is the obstructive phenotype of CLAD, and it consists of approximately 70% of CLAD.
My name is Aldo Iacono. I am the transplant director at USF Health, which is a center in New York, and I'm a professor of medicine and surgery here. Bronchiolitis obliterans is defined as greater than 20% decline in FEV1 from maximal individual patient FEV1 over a standard, generally a 3-week period. So prevention is one goal. Once bronchiolitis obliterans occurs, stabilization of function is quite important. In addition to stabilization, which is generally done with augmentation of immunosuppression and manipulation of anti-inflammatory medications, another primary goal is prevention of morbidity. Treatments are essentially not very effective for this disease, and mortality after occurrence of the disease is frequent, unfortunately. And the challenges revolve around using a potent anti-inflammatory drug to decrease the inflammatory response and the fibrotic response in the airways while preventing systemic toxicities, which are nearly ubiquitous with these pharmaceutical agents that are used. Cyclosporin and tacrolimus are the cornerstones of immunosuppressive regimens, and by maximizing levels, we suppress the immune response, and that in turn generally tends to ideally result in stabilization of lung function. One of the problems associated with calcineurin inhibitor use is frequent occurrence of nephrotoxicity and opportunistic infection. So these are side effects we have to deal with, in addition to traditional augmentation of maintenance immunosuppression. We also use other therapeutic agents such as montelukast, as well as azithromycin. Azithromycin is traditionally used for both prevention and treatment of bronchiolitis obliterans. One of the problems with azithromycin use is that a small percentage of patients show increase in FEV1. Azithromycin and montelukast, some patients do respond, about 50% in the azithromycin group. However, the response rate is limited, and none of these treatments have been shown to improve survival to any degree. So once we give the therapies, we hope to see stabilization of FEV1, but no therapy that I have seen has been shown to improve overall outcome. Generally, we augment maintenance immunosuppression to maximally tolerated levels, after which, or simultaneously, augmentation of systemic immunosuppression is given in the form of ATG. These therapies can be effective in slowing progression of decline in FEV1, but they're generally not effective in long-term management of these patients in reference to improvement in survival or alleviating the inexorable decline in FEV1 that's seen with this disease. Other therapies, such as TLI, have been used in the past. It's total lymphoid irradiation They're not used as frequently, and in my experience, we used it more frequently in the 1990s, but it is frequently associated with adverse events such as opportunistic infections. Photopheresis is an up-and-coming therapy that is used, and it's been shown to slow decline in patients with bronchiolitis obliterans, but the results are certainly not universal, and it's expensive and very cumbersome to do for individual patients. Retransplantation is certainly an option for patients who develop end-stage bronchiolitis obliterans, and we not uncommonly retransplant patients. However, there are obstacles to retransplantation. Firstly, it's not a procedure that's done commonly. And when we look at it, our databases, only about 5, at maximum 10% of patients are generally referred for retransplantation because of the complexities of the procedure per se. Although we like to offer retransplantation to all our patients, we always look at the risk benefit. There are only about 4,000 lung transplants done in the world or thereabouts, and donor allocation is an issue, and we must be mindful of proper use of organs. So donor use is an issue. The complexities of the operation with adhesions and removing the lung is certainly an issue. And quite a few studies, although it's controversial, have shown that outcomes are not quite as good after retransplantation. So for 50% of the population that develops bronchiolitis by year 5, only a small percentage of lung transplant recipients that are deemed to be candidates are lucky enough to get a second lung. It's not, therefore, an approach that one would use frequently that would be successful for bronchiolitis obliterans. My name is Aldo Iacono. I am the transplant director at Northwell Health, which is a center in New York, and I'm a professor of medicine and surgery here. There are a number of agents that are being studied for bronchiolitis obliterans as a disease of unmet need. These include antifibrotic drugs, anti-inflammatory medications, immunosuppressive drugs, and drugs that inhibit lymphocytes. The antifibrotic drugs include nintedanib, pirfenidone, inhaled sirolimus, and mesenchymal cell infusions. There's an anti-inflammatory cocktail that's being administered, including glutathione and ascorbic acid as antioxidants. Immunosuppressive drugs include liposomal aerosolized cyclosporin, alemtuzumab and rituximab are lymphocyte depleting agents, and itacitinib is a JAK inhibitor that is currently being used in experimental treatments for bronchiolitis obliterans. Lymphocytes have a pathogenic role in development of bronchiolitis obliterans. There are a number of therapies. Alemtuzumab is a drug that's been around since the 1990s and was used at University of Pittsburgh for induction. There are several articles from that institution that show that incidence of bronchiolitis obliterans is reduced, and that bronchiolitis obliterans can actually be treated effectively with this lymphocyte depleting agent. It has a profound lymphocyte and immunological depleting effect, and unfortunately is commonly associated with opportunistic infections, which complicate administration of using it for both induction and for bronchiolitis obliterans treatments. Rituximab is an anti-B cell agent, essentially, that's used for antibody-mediated rejection, which could be a precursor of bronchiolitis obliterans syndrome. This drug could be used as induction for patients with high PRAs, as well as for development of de novo antibody after lung transplantation, an event which is commonly associated with the development of bronchiolitis obliterans syndrome. There are a number of antifibrotic drugs that are being used as treatment for bronchiolitis obliterans that are in various experimental phases. Nintedanib is one, pirfenidone a second. Both of these are being used for idiopathic pulmonary fibrosis and fibrotic lung disease, with the intention of abrogating the fibrotic effect that's associated with bronchial occlusion and bronchiolitis obliterans. Nintedanib is an ongoing study, and estimated completion is within a year. Pirfenidone has been studied, and the results of this drug use have been essentially negative. Inhaled sirolimus is actively being studied in patients with bronchiolitis obliterans in a randomized trial. Results are estimated to be available in December of 2025. Mesenchymal cell infusion is also being studied as an antifibrotic agent. I believe this therapy is quite promising. There are a number of studies that are in the process of being completed. The Boston 1 and 2 are treatment studies that look at both single and double lung transplant recipients. The Boston 3 is a carryover study from these randomized controlled trials. The concept behind aerosolized cyclosporin is that large quantities of the drug could be inhaled, since the lung is in external communication with the environment. It offers an ideal situation for local deposition of cyclosporin into the allograft where the inflammatory response takes place. It's well known that cyclosporin and tacrolimus have narrow therapeutic indices, and therefore large quantities of oral drug or systemic drug cannot be given. The problem with systemic toxicity occurs when these drugs are given orally in large concentrations. So the inhaled therapy offers a therapeutic advantage in the sense that the drug could be administered in large doses, and that's been shown to occur by deposition studies, and systemic absorption from the lung is minimal. An anti-inflammatory effect thus can be achieved without the conventional toxicities that we see with cyclosporin-based immunosuppressive therapies, such as nephrotoxicity and opportunistic infections. In the studies that I have done, adverse effects when aerosolized cyclosporin has been added to the immunosuppressive regimen are similar to triple drug immunosuppressive therapies without aerosolized cyclosporin being given. In reference to other therapies, I would hope that the antifibrotic therapies will eventually have a role. Perhaps they can be aerosolized if systemic administration is not as effective as it should be. I believe that the aerosol route of delivery is an optimal route to treat lung transplant recipients because of the narrow therapeutic index associated with almost all of our systemically delivered therapies. The ideal route of inhalational treatment and treatments in the future could result in higher concentrations of drug being delivered into the lung, and most of our drugs, including cyclosporin, have a dose-dependent lymphocyte suppressive effect, so that larger concentrations of the drug will be delivered to the target site using a variety of immunosuppressive drugs, and that a cocktail of inhalational therapy could be used in the future, similar to how cocktails of therapeutic drugs are given systemically to prevent and to treat bronchiolitis obliterans and to prolong allograft survival and patient survival.